Call to order our board meeting. We appreciate everyone for being in attendance. We'll begin with our mission statement, which is to improve the health and wellness of Nashville by providing equitable access to coordinated patient-centered care, supporting tomorrow's caregivers, and translating science into clinical practice. Again, we want to welcome everyone. We call this meeting to order. This is an opportunity for each member to disclose potential conflicts and their belief that they can be unbiased and able to participate, or they elect to recuse themselves from the matter. Do we have any public comment? Seeing no public comment, we'll go over to our minutes. We're going to roll the adoption of our minutes to our next board meeting, if you all will allow us to do that. Was going to be a little bit of a task to get it completed before this meeting. So we will roll adopting the minutes until our next board meeting. All right, we'll begin with old business. And there is one item under old business that I would like us to revisit, and that is the CEO's performance evaluation, and also looking at the contract process for the CEO. And I asked Ms. Smith if she would lead those efforts, and I want her to give our board an update at this time. Chrissy, you're recognized.
Thank you, Chair. So we have 3 members of our committee at this point, one new member who was assigned and one unfortunately departed, who was our chair. So we, as a committee, would like to start out by stating we're looking at the first week, maybe the week and a half of December, as to have our first meeting. We're coordinating with Janet and the other committee member, but that is the target time frame. We would like to finish, there's 3 ultimate objectives. Chronologically speaking, we are looking at the review for July 2024 through June 2025 as our first objective. Second objective would be the contract, which for our CEO, which would be ending as of June 30th, 2025. And then thirdly, to go ahead and continue to evolve and establish goals for 2025, 2026 as we are evolving and revamping the goal process. On that note, and just to state, June 2025 at the year end of the contract, this is really important for many, many reasons, but I personally just want to state why I think these are important. Our city continues to grow and evolve, the community, and I want to make sure that we are putting our best foot forward and making sure our community knows about the good work that we're doing here. Secondly, we have a lot of third-party relationships, and those relationships are integral in the way this community hospital works, and want to make sure that that we continue to elevate those partnerships and continue to develop those relationships. Thirdly, we have a strong mayor in our office, and continuing to invest in that relationship as well, and making sure that we have the support as we consider building a new facility, and making sure that their group is on board. So those are things that I think that are really important for the future of this hospital, and that's why this committee is very important. For those of you who know me, you know, and those in the community actually know I'm not one to rubber stamp things. I tend to get really deep, and you know, our committee is committed to the due diligence process, and we are going to give this process in each of the 3 items I mentioned above the focus and respect that the position deserves. And for item 1, as an example, what Dr. Webb deserves, and his position and all that he's given to the hospital. So I just want to state that for the record. And again, this will be finalize the date, and then that information will be posted. So thank you for the time. And
May I suggest a correction on your evaluation for the chair, for the CEO?
of course, yes, sir.
That was actually the time period fiscal year 24,
24.
not 25.
Sorry.
So it was ending date June 30th, 2024.
Gotcha, 2024.
Just a correction.
Got it. Okay. Thank
Christy,
you for that.
what's the timeline? Do you have target dates for this? The first meeting is January?
First meeting being the first week in December, so in
December.
the next 2 or 3 weeks.
Okay.
Yes, sir.
And then, do you have an expectation for a report or?
Yeah, so the goal would to try to, between that meeting and a potential second meeting in January, to go ahead and have the first item to the board for approval in January. Any other questions? Thank you for your time. Appreciate it.
Thank you for that report. It's been many times we've been severely behind, so I appreciate you leading this and getting us on track. It is really important to the work we do. All right, we'll move to new business now. We have some policy approvals. Ms. Sales, you're recognized for 2 policy approvals.
Good evening. I am presenting, as mentioned, 2 policies. The first is the management of contracted services. This is in line with the Joint Commission requirements. I also met today with the Director of Quality. She is back in the back, Felicia, and we both identified additional revisions to this policy, which is clarification in Section E-D to clarify that if the contract is considered clinical contract, then it will go through the Quality Improvement Program, as that is in accordance with the TJC requirements. Also, the clarification will go into F to E to clarify for a clinical contract and the quality metrics. Now, Felicia and I will be working additionally to develop a clinical contract program within the hospital to address the quality metrics, and this will meet the TJC standard. Felicia also noticed, in our meeting noted today, that in addition to her report would be the clinical contract evaluation and review. So this policy is in line with the Center for Improvement in Healthcare Quality Accreditation Resource Services, which will be added as an additional reference to the policy. So my hope is that the board approves of this policy. As per the Joint Commission, we are following that guidance and having this policy approved at this level.
Any questions or discussion? I'll entertain a motion.
Move for approval.
Been moved and properly second. Are you ready for the question? All in favor, vote by the sign of aye. All opposed, ayes have it. Thank you.
Thank you.
We're ready now to hear your second policy recommendation.
Yes, Chair. The second one is the policies development and management. Again, this policy is in line with the Center of Improvement in Healthcare Quality Accreditation Research Services, which will be added as a reference to this policy. And this is following the TJC guidelines. I also met with Felicia today regarding this policy, and we'll make an additional revision to clarify that MEC is a delegated responsibility to approve medical, staff, and clinical related policies and guidelines. So all of this is in accordance with TJC and allowing for that delegation of authority to approve of policies and procedures.
Any questions or discussion? Seeing none, I'll entertain a motion to adopt.
Move to approve.
I'm sorry. Go
Move
ahead.
to approve.
Second. Been moved and properly second. Are you ready for the question? All in favor, vote by the sign of aye.
Aye.
All opposed. Thank you so much for your report.
Thank you.
All right, we will now have our foundation report. Chief Development Officer, you're recognized.
Yes, thank you very much, and good evening, Board. Really excited about this evening's presentation. As I've mentioned at multiple meetings, we have worked we are working with Pride Philanthropy, and we are doing a feasibility study for a capital campaign. And I, first of all, want to thank all of you so much. Many of you guys did the interviews, the surveys. Some of you did both. So thank you so much for your participation as well as for your feedback. And so we have Mary here tonight to give that feedback and give our overview of the findings. But before I formally introduce her, I also want to thank our board members that are here this evening, as well as the staff. Thank you so much. You guys are the best. And as I often say, you guys rock. So I have the absolute pleasure of introducing Mary Shirley Howell, a remarkable leader in philanthropy, and she will be presenting this evening. Mary is the Executive Director of Clinic Strategies at Pride Philanthropy, where her expertise and passions have guided countless organizations towards achieving bold and transformative funding goals. Throughout her career, Mary has left a profound mark on various sectors, including education, fine arts, scientific research, environmental initiatives, and health programs. Under her guidance, Pride Philanthropy has partnered with many hospitals, schools, and community nonprofits since 1925. It is a family business. And they've raised over $1.5 billion to fund vital missions. When Mary is not busy coaching and strategizing, she enjoys the great outdoors, often rowing and kayaking along the rivers and reflecting on the adventurous in her spirit. I have to tell you, we have to go out whitewater rafting one of these times because I love that too. So please please join me in welcoming Mary. She is true visionary in philanthropy and a true advocate for positive change.
Thank you for that. I'm impressed with myself now. Well, I'd like to echo Jen's thanks for having me here tonight, and also to echo her thanks for participating and being part of this process. And I recognize some of you around the room as people that I conducted interviews with, and it is a pleasure to see you and say, I know you from TV. So if you would, next slide, please, Sharon. So this slide tells you a little bit about the methodology that we used. Is a combination of surveys and one-on-one interviews that my colleagues and I conducted over the course of the last several weeks. We were testing to get the feasibility, to gather information around the feasibility of a potential $50 million campaign with the 4 topic areas highlighted that you see here. So behavioral health, an expansion to the medical arts program, comprehensive cancer center, and also women's health. Next slide, please. Through our interviews, we learned a lot about the strengths that Nashville General Hospital possesses. You're definitely viewed as a vital part of the overall healthcare landscape in the city of Nashville. That safety net role really distinguishes you within the community among those who know what you do. Now, you've got a unique position to address some healthcare disparities that are rooted in various racial, socioeconomic causes, not only by the delivery of healthcare, but also through your unique position in the educational landscape. This is a place where the interviewees expressed to us they understand that culturally competent professionals can be trained to work in these populations, both in Nashville and in other communities. While we're talking about workforce, I have to tell you about your staff. Your staff are seen as being not just workers, but people on a mission. These are people who are called to the work that they do here, and they are an absolute credit to the organization. Among the interviewees, call-outs of the loyalty, the commitment of the staff, and the level of customer service that staff provide on a daily basis was really a highlight. Additionally, there's an opportunity here in Nashville and Davidson County. Anybody who's seen the skyline here knows that there's tremendous capacity for wealth in the town. So there is the opportunity, there's definitely the financial capacity within the community to perform, to deliver on a significant campaign. Next slide, please. Whenever we were testing the different project areas, behavioral health was the one that across the board got high ratings. The other three topic areas kind of got some mixed results. Now, I wouldn't say that anyone was opposed to any one of those topic areas. They just generally expressed that they needed a little more information, perhaps a needs assessment. They wanted some real data behind it. There were concerns about the existing competitive landscape, say for cancer or for education, and they wanted to know if Nashville General was going to move into that space or grow its commitment in that space, how they would be expecting to really grow patient census or grow participant numbers to support a project like that over the long term. Next slide, please. Now, we also heard a lot about challenges here. One that came up initially was, of course, the age on the infrastructure here itself. Also, public perceptions around that it's an indigent care hospital. That doesn't necessarily line up with the reality of your overall operations here, but these are perceptions that were pretty widespread whenever we were conducting the interviews. Additionally, interviewees recommended that there could be some great benefits for Nashville General to deepen, to strengthen, and to find more alignment in its relationships with additional healthcare delivery partners, with healthcare education delivery partners, and with your elected officials. There's a bit of a lack out there in the public's understanding and in interviewees' understanding of what it means that Nashville General is a public hospital, and also the fact that Nashville General is a nonprofit that can receive donations. This is a pretty significant lack of knowledge that could be a challenge, could be a strong challenge in the face of a significant campaign. Now, Another issue that we realized as we were getting to know the organization a bit more is that your hospital foundation is still in the process of building capacity. What I mean by that is, in my other life, I'm an Army wife, and my husband likes to say that great units do routine things routinely. This is, if anybody knows anybody in the Army, you've heard this saying before. There are a lot of things whenever you're in a campaign, a lot of behind the scenes tasks that need to happen routinely, and your foundation is still getting there. You've got some great staff, some great leaders over there who are steering it in the right direction, but those are the sorts of things that really need to be on cruise control for a high-performing campaign. Additionally, there needs to be a lot more experience and training by hospital leadership, by volunteer leadership, to be able to really steer those efforts in the field of philanthropy. These are not insurmountable obstacles, I'll say that. Next slide, please. These aren't insurmountable obstacles. From Pride Philanthropy, my colleagues and I are comfortable recommending a $15 million campaign over the next 36 to 48 months. Now, that's different than the $50 million that we've tested for, but we're basing that number on the community capacity, on the list of prospects, those are prospective donors that were given as we went through the interview process, and on the foundation's recent fundraising performance. We believe, we would recommend that there is an opportunity to build significant organizational capacity performing a campaign of this size with a focus on major gifts. So we define major gifts as gifts of $100,000 or more. Those are gifts of a size that the Nashville General Hospital Foundation has not received many of. Next slide, please. A $15 million campaign offers a lot of opportunity for organizational growth. So it could build foundation capacity through the participation in the process. Both the hospital authority board members and hospital foundation board members would have the opportunity to gain skills in their role in fundraising. It'll give some time to build trust with donors. And as you know, trust isn't the sort of thing that gets built overnight. Be an opportunity to really engage other local leaders in the healthcare landscape, in the healthcare education landscape, and those elected officials to position this hospital as a key player in the public health space here in Nashville. Also, culture change, opportunity through this campaign to build a culture of philanthropy. And everybody knows that culture change doesn't happen overnight. I truly believe that a $15 million campaign would set Nashville General Hospital up for tremendous success in the future. The potential here, the appeal of the mission that you deliver on is tremendous. We've just got to get some foundation built to underwrite that. Next slide, please. Now, a pyramid of giving, this is just a tool that we use in philanthropy to kind of help us get our brains around the nuts and bolts of what it takes to make it to a particular goal. $15 million sounds like a lot of money because it is a lot of money, but you eat an elephant one bite at a time. And the giving pyramid breaks that down into the sizes of gifts that you need to get and the number of those gifts that you need to get to make it to your goal in a timely manner. As you can see from this, the largest gift that Nashville General Hospital would need to secure is a gift of $3 million. And I believe that that is a significant jump in size from the philanthropic investments that you all have received in the past. It doesn't stop there. It keeps going. But whenever we recommend a campaign like this and we recommend a concentration in major gifts, it's because major gifts are the fastest way to move the needle the farthest. Next slide, please. We totally, in getting to know Jennifer Baylog over the last several weeks, I can without a doubt, even though, I mean, she gave me a very flattering introduction, but even if she hadn't sweet talked me that way, I would have told you that Jennifer is a tremendous asset to the organization. We would recommend her for the primary staff role of direction and management for all fundraising activities for this proposed campaign, and also to quickly expand Nashville General's primary and secondary networks and access to individuals who may be donors. We would recommend establishing a philanthropy council of volunteers with initially 3 subcommittees beneath it that are focused on securing gifts either at a certain dollar level or from a particular type of community. So we have those delineated as signature gifts, those are 6-figure and above gifts, business gifts, which come from the business community, and then something that we would call special gifts that land somewhere between that $10,000 and just under the 6-figure mark. These would be gifts that could be pledged over time, so 3 years, maybe even up to 5 years, depending on the donor's preferences. And the good news is that 14 people who interviewed said that they would be willing to serve in some capacity in these committees. Next slide, please. If you're a little more of a visual person like I am, this is how these committees would be set up. You see over here on the right, there's annual gifts and plan gifts. Those would come at a later stage of the campaign, but they would be ways for potential donors to plug in through different mechanisms or at different dollar levels. Now, what you may notice is that this is not a board. The Philanthropy Council would reside separate from the Hospital Authority Board and the Hospital Foundation Board because it would be purpose-built for the purpose of raising funds. We would not want this group to be distracted by all of the governance issues that governing boards need to address. These folks would be for fundraising and fundraising only. Now, Hospital Authority Board and Hospital Foundation Board members would absolutely be invited to participate in the Philanthropy Council and in its committees. It would be in addition to your existing hours of volunteer service and not instead of. So if you're signing up for that, then you're signing up for a few extra hours of volunteer service each month. But this is a great way to quickly multiply the reach of the philanthropy operation here. Next slide, please. Another important piece of the overall puzzle for a campaign is the case for support. This is just what it sounds like. It's making the case, like if you were going to argue it in front of a judge, making the case for why someone should make a donation to Nashville General Hospital. Now, what we would recommend is a story arc that may be a little bit different than some of the story arcs that are currently told about Nashville General Hospital in this community. Start out with some context, explaining to the audience about the unmet need for the patients that you serve, and then begin to share the vision. There's a vision attached to whichever projects are selected for this proposed campaign. Back that story with some data, and then invite donors to dream alongside you for the new reality that their gifts could create. Through that case for support, you can really leverage some of your organizational strengths, particularly the position in the community to address health disparities, but also the long history that this hospital has in this town. And also transparently address gaps in that case for support. There's a lot more detail on how to do this in the full feasibility study. Next slide, please. We'd recommend a three-phase campaign for the timeline of it. So the initial phase, you might, if you've been in the midst of a philanthropy campaign before, you know of the silent phase, this would be the quiet phase of the campaign. The first 12 to 18 months, there's actually a whole lot of work to do. We just don't talk to a whole lot of people outside of the organization about it. We'd be working on building internal capacity in the foundation and also leading by example. So you'll see that the second thing on the to-do list there is 100% commitment from hospital leadership and the boards supporting the hospital. It makes a strong statement to philanthropists and funders in the community when you can go out and say that 100% of the executive leadership, the hospital board, and the foundation board have made significant multi-year pledges. We recommend doing this not because it's pay to play to be on a board, but because it's a way for us to lead by example. And that is our position as board members. We are showing the rest of the community how they should behave toward the organization that we serve. And we're also demonstrating our absolute faith in this organization's ability to deliver on its mission. We'd be refining the case for support, recruiting and training those fundraising volunteers. And then at the end of probably about the first year, maybe year and a half, we might actually review that financial goal. Depending on the gifts that have come in at the end of the quiet phase, you can sometimes recalibrate your goal. Sometimes it goes up if enough gifts have come in during the quiet phase. The public phase lasts about a year, and then we get to the 6 to 12 months where we party and celebrate all of the work that we've done, close the last gifts, and then wrap the campaign up. Next slide. This is the immediate to-do list that we would recommend for the first 90 to 120 days if a campaign is approved. You see, the first step is to approve the campaign and projects. Since we tested for those topic areas and behavioral health was the one that came up on top, there may need to be some internal conversations and conversations with your partner organizations to figure out exactly what would be the best projects to pursue. You'll also want to involve Jennifer Bailog because she's going to have a handle on what the most appealing projects for donors would be. Pursue that 100% giving from the leadership, build the case for support, on down. These are the things that I've already described a bit, all the way down to the nitpicky updating fundraising policies and processes and making sure that we get some of those routine things routinely documented. Next slide, please. So those would be our recommendations based on the interviews and surveys that we've conducted over the last several weeks. I'm absolutely happy to answer any questions that you may have at this time. Oh, yeah, Courtney.
Do me a favor and go to the microphone.
Courtney Fulham. For a hospital this size and a city this size, what type of campaigns would you recommend?
Explain what you mean by what type of campaigns.
Well, the campaigns to raise the $15 million.
Well, we recommend a campaign focused on major gifts. So major gifts are generally one-on-one, face-to-face asks for significant multi-year pledge gifts. I'm never going to be the person to stand up here and tell you to have a gala. I'm staunchly anti-gala. I started my fundraising career in walkathons, and I will never go back there.
Okay. All right. Thank you.
What, and this may be for the Philanthropy Council to decide, what pitch do you make? You know, we're a hospital that has a pretty good subsidy from the city. How would a $15 million endowment, how would we try to sell it that it would change what we're able to offer or how strong we are? You know, I kind of understand $50 million that would go towards a new facility, but what do we tell them they're going to get for $15 million?
So I heard you say a $15 million endowment, and I would clarify that right now endowment is not specifically on the table. For those of you who are not familiar with that term, an endowment is just an investment account from which the proceeds of the investment are what gets spent. Large institutions like universities and hospitals often do have endowments. It's one of the things that makes them very stable organizations in the philanthropic landscape. But I would not actually suggest that this be a strict endowment campaign. Now, that being said, according to whatever the projects are that would be identified, behavioral health was the one that tested well, but I don't know exactly what those programmatic or service line improvements might be for that. That would be what you would really build the case around. Philanthropy is always margin of excellence money in any organization, whether it's a state university or a hospital that's public, that's partly funded either by the state or by a governmental organization. That's always it's the difference maker money.
So I mean, I would agree. So we would want to tie this $15 million to specific projects to enhance the hospital.
Correct. And also, you know, when you work in, when you're raising money in that major gift space, you essentially wage a campaign tailored for one particular person. So that $3 million donor is going to get a very tailored message that is going to resonate with them through the process of connecting with them and cultivating them, getting to know them, building a deeper relationship with them. We'll find out what would be appealing to them that also aligns with the work that we want to do here. And so that's where the magic happens, is in that process. Yes, sir.
Yes, I wanted to point out that ironically, the two programs or the two services that were more in question, behavioral health was obviously supported, but School of Health Sciences and the oncology program, both close to 100 years old and have been very successful over the years. So it says something about what people actually know about the hospital. Those are two of the most prominent programs, and again, both very successful and still. Yeah.
Yes. I definitely, in the interviews, we heard positive things about those. We just also heard people asking questions. Do we have, or do the other educational organizations in town not deliver enough people? Do we not have cancer covered with the other cancer with the other cancer centers in town? And, we were not in a position to answer that question for you. Just wanted to report back that people had those questions. Anything else?
Yeah. How would this potentially either assist or conflict with the potential for approval of a new hospital and movement of a new hospital within that 36 months?
So one of the things, we were sensitive to that possibility when we were really thinking through this. And what we recommend is that anything that is, any funds that are raised for this be raised for projects that are portable, that are movable. Oftentimes, in hospitals and universities, large institutions, you see a whole lot of naming opportunities for the atrium, for an oncology suite, something like that. The possibility of relocating, I would actually advise against naming physical spaces, because then you would have like the conflict of, well, what do we do when we move to the new place? Do we put the same name? Do we move the name to the new place too? And while that's still kind of in limbo, the timing for that is not determined. I would suggest focusing on programs, focusing on staffing, focusing on things that could easily be moved to a new facility whenever that happens, but that would allow the foundation to build that process capacity through the campaign itself, and also allow the organization to begin building trust with donors and to begin building visibility in the overall philanthropic space here in Nashville, because that was really a challenge to hear that, people don't know they can make donations to General.
May I ask a question just to set a baseline for this and understand what that baseline is? Because you said there's some internal capacity building that would have to be done. Has the foundation of the hospital done a capital campaign before? And when was the most recent campaign, and what was the outcome?
To my knowledge, there's never been a capital campaign here.
Okay, so we don't have a baseline from a previous campaign. And you said that the $3 million principal gift that we're forecasting for this would be larger than previous gifts. What is the largest gift to date to the foundation or the hospital?
$100,000. It would be a significant leap, but because of the financial potential in Nashville and because of the role that you all play in addressing healthcare disparities in this city, we believe it will be aggressive, but we believe that it is a reasonably aggressive leap to make.
And just so further baseline, no, thank you for that information. What is the foundation's, not just single gift, but general trajectory or average sort of what are we doing in philanthropy each year on an average basis?
Currently, it's in the range of $250,000 to $300,000 a year, correct, Jennifer? Yeah. So that's currently where it sits. It's my understanding that it has only been actively staffed for about 9 years, even though it's legally been in existence. It was just sort of passively there so that if gifts passively came in, they could be accepted through this legal entity. But it's not been, I would say it's not been utilized to its maximum potential.
And that does seem like the opportunity that we have at the start of an infrastructure. And that baseline information is really helpful, I think, going forward to understand how to approach this. I absolutely agree with you that we
live in a community. We live in the healthcare capital of the world, if we were so inclined to say. Maybe that's an overstatement, but we certainly live in a healthcare city, and we have many resources. So that is very encouraging about what we'd want to do. I think I would agree that, and maybe suggest when we get to this point, that a critical part that we ought to spend time at the beginning, if we embark on a campaign like this, is to understand what the need is and what we are asking people to contribute to, because I am certain that there are such needs that the hospital meets and can meet, and it will be really critical, I think, to start with that and identify what it is that's the compelling story. And when we identify that, I'd be really encouraged to figure out how to go about funding it.
Yes, absolutely. And you know, that discovery process for that was not something that this was really in a position to discover, but you know, I think the other healthcare delivery partners in town, the other healthcare education delivery partners in town, to have them at the table and to be able to develop that trajectory together would be incredibly powerful, and you know, would definitely set a campaign on the path to need to do a serious readjustment at the end of that 18 months and bump that goal up.
Well, I really appreciate that, and I appreciate all the work that you've done. Listening to your presentation and even being part of the interview process really got my wheels spinning about possibilities. So I think this kind of dreaming about what is possible and then how to achieve it is really important. And thank you for your presentation, for your work.
It has been my absolute pleasure. There is so much possibility. There's so much possibility. Did anybody else have any questions? I know you have a long agenda. Thank you so much for your time.
Let me ask you one other question. Are you thinking a combination of restrictive and unrestricted gifts?
Ideally, yes. It is normal for very large gifts to be restricted to a particular project, a particular purpose. And then as you move down into, into those annual gifts that we were talking about, that kind of fourth committee over on the right, it's unusual for, a $50 gift that people are willing to let it go to the area of greatest need within the hospital. Those are very flexible dollars. And that's part of what makes philanthropy the margin of excellence money that organizations like to pursue. But, that $3 million gift may be the naming gift for a specific behavioral health program that a philanthropist really latches onto and is excited to bring to reality. Now, that doesn't mean that they're going to be prescriptive about, you'll hire this type of person and that type of person. Like, wait, we have to wrestle some of that back to the organization. But yes, it would be a combination of the two.
Thank you for your work and thank you for your presentation.
Absolutely. Thank you for your work.
I did hear you say that there were some members of the foundation board and some staff here. I'd like for them to stand just so we can recognize them. We hadn't had a lot of interaction per se with the foundation board and those staff members, so we want to recognize you. Thank you for your work. Thank you. All right, that was for informational purposes, so we'll move now to our quality report. Stinson, you're recognized.
Good evening, everyone. We're going to change things up a little bit this evening where we're not going to go over metrics since we were kind of delayed with trying to get the report out, but I'm happy to report that we did complete our Joint Commission Triennial Survey, so I'm going to give an update today on it. The verbiage is in your report if you want to refer to it, but I wanted to just share some details. Some of it kind of bleeds over from our foundation report from some of the findings that were noted during the survey, but also to share with you some of the ways that the board as a whole can help support us in ensuring that we do continue to maintain our deemed status with Joint Commission. As I stated, we had our survey. It was 3 days, November the 5th through the 7th. We had a team made up of 3 surveyors. Our lead surveyor was a nurse. very experienced in Joint Commission surveys. We had a physician surveyor as well as a life safety surveyor. And as you know, the purpose of the Joint Commission survey is for them to come in and do an overall evaluation of how well we provide high quality patient care and also to maintain optimal patient safety practices as well. One of the things that impressed me that Joint Commission did share with us this year, they kind of gave us a synopsis so that we could understand the depth of the assessment and how much effort is put into 3 days to be able to assess the facility. They shared with us that during this 3-day survey period, they assessed a total of 263 standards, 12 national patient safety goals, 1,403 elements of performance, and 3,069 conditions of participation. That's a lot of work in a 3-day period, which totals to actually 4,747 standards that we were evaluated against. And during this survey, every hospital loves to have 0 findings, but no hospital has this. So I want to put that out there. We were fortunate to come away with only 30 findings out of 4,747 standards that were assessed, which means that we were complying with more than 99% of the standards as a whole, which is huge for our organization to have that established for us. I wanted to share some things that went well during the survey. The survey team was extremely complimentary of our organization's commitment to providing high quality patient care. And the reason why they shared this with us, because in conversations not only with leaders, but also our staff, they did see a strong commitment to this organization to address social determinants of health, but also to making sure that we are providing not only the basic needs, but ensuring that our patients do get a high level of care here. One of the things that they shared with us in particular, they were extremely impressed with our ability to be able to shift in the moment where we were the lucky recipients where they decided to share with us that Joint Commission was moving to a model next year to do a lot of electronic sharing with documents and policies and charts. Quickly, I don't see Melanie in the room, but there she is in the back. I wanted to give her a huge shout out because they gave us the opportunity to test this model. In the moment, we were notified on day 1 about this, and they asked, do you want to see if we can make this work because this is going live January 1. And within 2 hours, Melanie and her team were able to stand up a SharePoint site where we were able to do electronic data submission, which they were extremely impressed because, like I said, a lot of facilities are not able to do this right now. But we were able to stand it up in a matter of 2 hours. So that really set the tone with the surveyors that we were ready and organized and were willing to meet the challenge during the survey. Also, during the quality assessment and performance improvement session, what we normally do is we provide Joint Commission a list of quality and patient safety projects that we've worked on over the last 3 years. And they particularly sought out our No Way ED project to highlight where they brought in physicians, nurses, support staff who were involved in that project. And they were so impressed with the No Way ED model that the lead surveyor decided she was going to borrow our model and take it back to even her home hospital. So we were able to achieve no findings during that session. Also, they were extremely complimentary of our emergency management program. And I know being in the Nashville area that we might not be hit with the same disasters as a lot of other areas are. But they were extremely impressed that we stood ready and also have one dedicated leader who oversees this program and the discussions that took place around cyber attack, weather-related incidents. They were extremely impressed with our level of preparedness and also, too, the level of depth that not only our leader was able to share, but other individuals who participate in the committee. So that was identified as a leading practice as well, considering the size of our facility, that we had that level of engagement as an organization. Next, our medical staff leaders. I see some of you in the room here. I wanted to recognize Dr. Nezare, Karki, Turnovitz, Pierre, Karki, Stokes, and Abu Ali. They all participated in the medical staff leadership session, which this is something that is new. The Joint Commission necessarily didn't have separate sessions with physician leaders, but I'm glad they did because our physician leaders were able to demonstrate not only medical staff operations, but the way that we do business and how the medical staff is intertwined with quality without any prompting, they were able to share their role in with the various service lines and how they work with our department and the organization to achieve high quality care. And also during our leadership session, many thanks to Chairman Stevenson. He joined this because they asked particularly for a board member, which a lot of times many facilities really struggle to get a board member to actively participate during these sessions. But Chairman Stevenson, as well as our executives, our nursing leaders, quality and medical staff leaders, were very engaged in this session, to the point that our physician and lead surveyor shared with us that they were not only impressed that individuals were willing to share, they were able to see information they heard from various team members throughout the survey resonated all the way up to the leadership level. So it was impressive to see that during that session. But also, Dr. Alicia Fair, she's sitting back there in the back, when she gave her presentation on our food pharmacy, one of the things that our physician surveyor was so impressed about was the way that we're using research in particular to be able to draw individuals to join us in clinical trials, and also to address food insecurities in our patient population, where they did highly encourage us to seek out the Tyson Award, which many organizations do not achieve this, and to have Joint Commission to tell us that they felt that this model was impressive enough to be able to achieve that designation is huge. So Dr. Fair and others in the organization now are submitting our application for the Tyson Award. And with the Tyson Award designation, what it deems is that our organization demonstrates a measurable improvement in health equity and how we address that from a quality and patient safety standpoint. So those were all the accolades that we received during the survey. What I'm going to shift now is to our opportunities, where we have to be able to continue to improve how we deliver care as an organization. Under environmental care, everyone knows this is an old building. We do the best that we can to be able to maintain as best as possible, but we did receive several environmental care and life safety findings because of our infrastructure. So we are working on addressing that as best as possible. Some of these are building, some of these are furniture related, but we know it takes money to be able to make these things happen. They were extremely understanding that we are heavily seeking the ability to be able to build a new facility. Chairman Stevenson addressed this during the leadership session, but nonetheless, they can't overlook those particular findings where we need to make those improvements. Also, there were some concerns around electrical and radiological safety, nothing that was considered an extreme threat, but nonetheless, opportunities for us to improve. Under human resources, we do have some opportunities to make sure that we consistently monitor staff certification so that when staff are working, that their certifications have not lapsed and they're current and up to date. Under infection control, there was findings related to equipment cleaning, and this is dealing with our surgical services, and I'll get into that in a little bit later. Under leadership, Susanna Sales talked a little bit about contract management. And we did have one finding dealing with contract management, and that's the reason why Susanna wanted to bring this policy to the board for awareness, where anytime there's a clinical contract, we're required to have some type of quality metric where we can evaluate that vendor's ability to be able to provide care. And if they're not meeting those expectations, we as an organization have the right to be able to end that contract and seek service with another vendor. So there was one finding out of the 3 contracts that were reviewed in relation to that. Also, life safety, there were some concerns around general fire safety, and this does have to do with the building and the environment, and we're working to address those. Under medication management, there were some findings dealing with patient pain management and reassessment, and we're going to be working with our nursing and physicians as well as our residents to ensure that we have the optimal documentation and how we monitor pain assessment. Under provisions of care, there were a couple of findings in our kitchen related to food safety. But as I shared before, these are not critical findings. They're more so around labeling of items and making sure that we're wearing the appropriate safety garbs in those areas. And then also in that same chapter, there were findings related to patient restraint assessment, and this does deal with documentation. As I shared, no immediate safety concerns, but making sure that our documentation aligns with our practice. Under rights and responsibility of the individual, we had one of three patient grievances that were evaluated where we did respond to the grievance within the 30-day time period per CMS guidelines, but the timeline was delayed. I think it was like 45 days that was noted. And we're working with that team on that as well. And then last but certainly not least, this was not a finding dealing with provider evaluations, but one of the things that Joint Commission impressed on us is that they want us to fully implement our policy where we have an evaluation of our providers on initial appointment, when new privileges are added, and then annually thereafter. And we're going to be working with our MEC to bring that forward. Some items that were not listed as findings, but Joint Commission wanted to just tell us, hey, you guys may want to consider this because it's considered leading practice and can help you operate more efficiently. They did encourage us as an organization to invest in leadership training for our medical staff. Even though our medical staff leaders rocked it during the medical staff leadership session, there was some discussion on whether or not we invest in dollars to be able to make them aware of what their expectations are as they lead various service lines and serve in leadership roles in the organization. And our foundation is going to be working with us to see if we have dollars where we can target at least 2 providers to start with, and then along the way be able to train up additional physician leaders to assume these roles. Also, they highly encouraged us to implement multidisciplinary peer review. We have peer review here now, but it's down to the service line. So we're going to be working with our service lines to bring that along under one multidisciplinary group. And then last, there was a recommendation that was made during our leadership session where there was discussions around making sure that our providers here at Nashville General understand their responsibility to the board when it comes around to quality and patient safety. And the question that was asked of us is, do we have a Nashville General provider on our board? And we don't. This is not a finding for the organization, but they made it very clear, be it that our providers have a duty and responsibility to the board, that we should strongly consider having at least one Nashville General provider on our board. So next steps. We are required to submit our plan of correction by January 12, 2025. But with this, we did receive a condition of participation finding around surgical services. And I want to let everyone know that this is not an uncommon finding. There's actually 6 different condition of participations that your facility could be cited for. And the one that we were cited for is easily fixable, to the point that within the last 2 weeks, we've made major strides to be able to resolve this. With this, we will have a short abbreviated resurvey. It'll be one half day, one surveyor. They'll come back and assess the areas where they saw this finding. It's not a full-blown survey, but we're confident that we'll be able to pass this. I wanted to just let everyone know that when you hear conditions of participation, some people assume that's immediate jeopardy. It is not the same. Immediate jeopardy basically ends your accreditation in the moment. Your facility is considered an immediate threat to safety. That is not the same thing. Conditions of participation only means that your hospital doesn't meet the minimum standards for a particular area, but as I shared, what was found is totally fixable. And just a reminder, 65% of hospitals receive a condition of participation. It is not uncommon. One of the things that the surveyors did share with us, we came extremely close to having a condition of participation over our physical environment. That is just because of the number of findings that we're dealing with the building itself. But they made the decision to not issue that conditions of participation because of the constraints that we have with the environment. And their central office did support that decision as well. So overall, I know that was a lot, but it was a very successful survey. Many people in this room had a lot to do with the surveyor that led to its success. We're still accredited by the Joint Commission, and now I'll take any questions.
What
Yes.
was the what was the big problem in the operating room?
It wasn't the OR. When Joint Commission says surgical services, it can mean anywhere where surgical instruments are stored. So it wasn't our OR that was the issue. It was storage and where instruments are stored outside of the OR, which is totally acceptable. And many organizations store surgical equipment, like in our surgical clinics. Here we have OB, of course. We do have issues with being able to maintain humidity. Like I shared before, it's because of the nature and the age of the building. It makes it very difficult, especially as the seasons change and you have those drastic shifts. We are working with a lot of these areas to try to move towards disposables, because disposable instruments and how they're packaged from the manufacturers are a whole lot easier to maintain in those settings where you can't control humidity and temperature as much. But it was not dealing with our OR.
I have a question. Well, first of all, thank you for such a thorough report.
You're welcome.
And congratulations on a successful survey. It's outstanding. I have a quick question, and it may actually, Melanie, I'm looking at you. You may be able to chime in here, but I'm wondering the pain assessment for patients as well as documentation of patient restraints that was noted, if that is something that can be embedded in CERNA, that would be an easier kind of check the box for those providers as they make rounds to satisfy not this deficit, but this issue.
Yes,
Thank you.
great question.
Yes, that's something that we've been working on for at least the last 9 years, and we make little tweaks, but our limitation is our EMR. So that is definitely one of the things that we looked for in our search as we chose our partner. And with our Oracle Health Cerner implementation, we will have more streamlined pain assessment, like in one place. And as you hear me talk about one patient, one record, it follows the patient through wherever they are seen in the organization. So yes.
Did the survey spend any time talking about cybersecurity?
Yes. Melanie could probably speak to that, because I know it came up in our emergency management session.
Yeah, as she mentioned in the emergency management session, they did ask us a series of questions about what we are doing. We did reference the issue we had a couple of years ago and all of the things that we have put in place since then. They were very impressed with the whole environment of care survey and did speak to the level of things that we did. A big help was Mike. Mike Larson did a fantastic job, but also in the room you could tell that everybody in the room knew what they were talking about. So it wasn't just defaulting to one person in the room, but every level, managers, we had frontline support staff, everybody was on the same page. So,
I mean, this has become a real cat and mouse game in big institutions, particularly healthcare, and it's probably something that we need to be kept apprised of if you need additional resources. Because what may work today may not be adequate 6 months from now.
yeah, this year, also as a result of our incident a few years ago, a couple of months ago, we hired a new director of information security so that it is not just a piece of somebody's job, but it's somebody's actual job to stay on top of it. And he is working on putting a lot of processes in place in a very streamlined way. And so we're really lucky to have him. He comes with a lot of experience, and we're seeing changes already.
Thank you. Oh, go ahead.
Can you push that button, the other one? There you go.
Excellent job. I really appreciate this and am very excited. So kudos to everyone. And it's an ongoing process. With the human resources monitoring staff certification and then also the provider evaluation policy, I kind of see those two things together, in addition to the recommendation or at least their suggestion of providing professional development and things of that nature. And I know you have to kind of quickly respond to those things. Do you have a plan in place, or are there funds available for professional development, or do you already have some type of metrics or who does the evaluation and how are they to be evaluated to evaluate? So, I mean, there are many, it's several layers. It's a complex question, but it is a very difficult one, which is so important to maintaining the excellence and high standards and to make people want to come to work.
Yeah, I completely agree.
Yeah, so
You
just
kind
a
of
little bit
answered the
about it.
question kind of sort of already, but one of the things we found out during the survey is that they did challenge us on how do you validate that your subject matter experts are truly subject matter experts. So we did have that conversation, and normally with the accrediting bodies, a professional certification achieves that. So that kind of ends the discussion at that point. But that's for our staff level. The finding that we had was not that staff did not have initial certification. It's just unfortunately their certification had lapsed. And I think the one that they found out of the like 20-something employee records they reviewed, it had lapsed by like 2 weeks. But of course, Joint Commission doesn't give you grace over time. So we are working with our HR partners to make sure that our leaders are aware that when that does come up, that we do have to sometimes make that tough decision to remove people off the schedule to be able to do that. But we want to at least have notification well in advance so we don't get to that point, so we have the appropriate staffing to care for patients. That's for our non-physician staff. For our physician staff, it is a little bit different. Because the way that their evaluations work, they are service line specific. Well, as an organization, we do have to decide on metrics at the service line. There's some that we will do like length of stay, readmission that every provider has. But when you get to the specific service line level, like surgery, OB, there are national metrics out there that we do have access to so that we can be able to benchmark them against those national standards. We do have a policy in place. It's been in place for some years, but unfortunately, due to staff and leadership turnover, it lapsed. We were well aware of it. We were transparent with the Joint Commission about it during the survey, and they honored the fact that we were transparent about it and that we were actively working on it. That's the only reason why we didn't have a finding. But we do have a plan in place. Our policy, I see Dr. Nezare in the back, will be going to MEC probably next month. We've been working with Dr. Nezare and Dr. Katz for the last 2 months, actually, to make sure that we were all in agreement in how to move forward with this, so at least we can be able to sustain it long term and transfer the responsibility to.
Thank you.
You're welcome. Thank you.
Thank you for that information. If you would stay for just a few minutes, we do need to approve this report. So I'll entertain a motion at this time.
Move to approve.
Thank you. All right, it's been moved and properly second. Are you ready for the question? All in favor, vote by the sign of aye. All opposed, ayes have it. And again, thank you to the entire team for some really great work and being prepared. Medical staff reports. You recognized.
Thank you so much, and good evening. Felicia Denson's a tough act to follow. For the board's information, I present an update on the medical staff bylaws. I will be reconvening the bylaws committee in early December, that is in the next couple of weeks. And though I don't expect to have updates to share in those first weeks or perhaps months, I do expect updates down the road, be taking a slightly different approach. I'd like to focus on where we don't agree so we can all find a document that we're equally comfortable with. For the board's approval, I present the credentialing report. I won't read the list, but I will draw your attention to a couple of service lines. We have Dr. Edwards, our new pathologist. If you look at behavioral health, you'll see the medical director for behavioral health, Dr. Frank Drummond, as well as on his team, Roz Pope, nurse practitioner, and Clark Simmons, social worker. Finally, 3 new CRNAs for anesthesiology, that is in the operating room. I will close there. I am happy to answer any questions or speak to anything that the board would like to hear on.
I just had a quick question with Dr. Drummond. His psychiatry license will expire 3/25. So I assume that that's in the work, since we've just got through talking about certifications and things of that nature.
Absolutely. Dr. Drummond's not going anywhere.
Okay.
And he's on it. And I'm on it. Yeah.
I just want to make sure we're on it. Yeah.
Absolutely. No, and I appreciate you bringing that to our attention. This is the individual who's building our behavioral health program. Keenly attentive to detail. So I suspect that hasn't been missed on him.
It's very difficult when you have to get your CEUs and all these other kinds of things, and they come very quickly. So
Most of us do it the night before they're due, in fact.
yeah, and you can't.
Yeah.
All right, any other questions or comments? All right, we will need to approve the credentials report. So I entertain a motion to adopt the credentials report.
I motion to accept the credential report.
All right, can I get a second? Been moved and properly second. Are you ready for the question? All in favor, vote by the sign of aye. All opposed? All right, thank you. All right, we are now at our finance report. Bruce and Chrissy, you're recognized for, oh, Chrissy's gone, but she did have to leave. I apologize. Yes. Mr. Naramore, you're recognized for our finance report.
Thank you, Chair. Month of September financial reports, our general statistics for the month. It was, again, a pretty busy month, 226 admissions, 191 observation admits. We had the first time since we opened the no wait ED where the volume actually dropped for the first time after really 5 solid months of increase. Anyway, ER dropped back just a little bit this month. Clinic volume was 4,550 visits. I would point out also that our surgeries this month, it's been a concerted effort to work in that space and get those referrals captured and on the schedule as soon as we can. Inpatient surgeries were 60, which was more than double the budget of 27 cases. And last month, I think we had 39. And then 103 outpatient cases, surgical cases, which was also about 18% above budget, a little bit behind last month. The cath lab volumes were low. You know, the cath lab has been down for construction, renovation, replacement. So that continues to be light. It's just the interventional work that's being counted in there. And then deliveries for the first time in several months were actually at 35 and above the budget for the month of September. So that was positive. I would say that, you know, when you get into the financial statements themselves, you'll see a few things. First of all, gross revenue was about $3.5 million shy of the budget. Even though our admissions were on the number, our patient days were a little bit less than the number, so less gross revenue. But the quicker we get patients out, the better it is for us financially. Length of stay was 3.6 for the month, and year to date, it's just below 4.0 days. So that's about 15% better than it was a year ago, length of stay wise. But anyway, for gross revenue on the inpatient side, it was about 11% shy of budget. On the outpatient side, about 13%. Most of that is we have not had cardiac cath revenue, right, with the cath lab being down, and we didn't have a practitioner since Dr. Akama departure in the summer. So anyway, those will be coming back online. That gap will be filled. Our ER volume was a little bit short. Observation days are down because we're taking care of those patients, concluding on them very quickly, and that's causing the gross revenue to go down, but not the net. So the nice part is, even though we were $3.5 million shy on gross revenue, the net revenue at the $5.14 million was almost right on the number for the budget for the month, about $50,000 short. Elsewhere, our other revenues in total, we were at 13.1 for the full month, about 300,000 better than the budget. But where we suffered in September was on the expense areas, salaries and benefits, about 550,000 above budget. And then our other expenses, we had some pretty significant expenses around IT, Microsoft licenses and so forth that we had to renew. And because we've got so many more people that are being attached to the system, that was about 130,000 that we did not anticipate. And also the sterilizer down in the OR and also the robot. Those two were expected to be capital purchase. They ended up being leases. And so those three things were about 230,000 above what we had anticipated when we put the budget together. They will be with us for the rest of the year, so that variance will continue throughout. The other big variance was in physician services. Some of that is catch-up. A few months ago, we approved an addition to the radiology contract that was about $500,000 to cover trauma. They needed an additional body. And then the pathology contracts that we did for when Meharry basically didn't have the pathology staff to cover the lab for us. We brought on Prime Pathology, and then now we're bringing on Dr. Edwards as a second pathologist. Those were unanticipated in the budget. We pay Meharry about $11,000 a month. These two new providers contracts are going to be about $900,000 a year. And because they started back in May, I had to take all of that retro and get it up to time frame of September. So it looks much heavier than it will be next month, but those are realities of things we have to do sometimes when a hand is dealt to the hospital. We have to keep a lab intact. We have to keep radiology services here. And we have a trauma program that is developing. And we have a no-wait ED that is hopefully going to be feeding that trauma program as we go forward. So total expenses for the month were about $2.1 million above the budget. And that created a net loss for the month of $1.7 million. I will mention one other thing. We talked about it at finance, is that with the Cerner conversion, we're down to the last, we're within 30 days now of going live with that system. We have 18 full-time consultants here helping everything from patient access to nursing to women's services to IT. And those are expensive resources, and just rough estimate for the month of September, about $330,000 of contract labor and probably another $70,000 of travel and housing and so forth. So we're going to still have that for the next couple of months. It was not budgeted. It's more significant than we anticipated, but we do believe, and Melanie's back there, that the bulk of those 18 people will exit shortly after we go live, probably January 31st, January 15th, and then that variance will move away and we'll go back to regular business. But that is something that we're looking at. We've been looking, certainly all of us, looking at the expenses and where we can sort of narrow that down. But we had, a cacophony of odd things that hit us in the month of September, and we had to bring them in to the income statement. So it's not a great month. It was a good volume month, but just a poor financial operation month because we had to do a lot of catch up from prior months. So that's what we talked about at finance, and I know our chair had to step away, but I'm happy to answer questions, sir.
A few questions. So we didn't budget these 18 consultants when we originally decided to purchase a new EMR. We didn't anticipate that.
We did not. No, we did not. Now, the other issue was that, if you remember, originally we were going to go live with Cerner in June. So we didn't have 18 consultants expected back in June either, but we certainly didn't have them in December or January or whatever. Yes.
Because that's always part of implementation of a new EMR, is that you have that. The second thing is the $225,000 that was not budgeted for the sterilizer and the robotic system. I never remember us deciding to purchase either. So shouldn't that have been part of the original budget?
They were both in our capital budget. Both were in our original capital budget, $7.3 million. Remember, we got the Metro money. Right. But we've had to use that money in other areas, so we ended up, and it wasn't that much money. It was $36,000 a month for the robot, and it's a little less than $60,000 a month for the sterilizer. Yeah. So the other 130 was Microsoft licenses that were not, that caught us a little off guard.
And then the contract nursing went way up last month.
Contract nursing?
Or contract labor?
Contract labor included that $330,000 of the IT sort of consultants. Okay. Just, that's where it's really off a a little bit above what we had budgeted. And that's where most of the significance is, Dr. Miller.
Can I ask a question on Dr. Miller, do you have other questions? A question on the revenue side. You
Yes.
mentioned, it seems like the lack of an IV cardiologist and the cath lab being not fully operational or having an impact on the budget. And I think you said that that's going to be back online. What is the timeline for having a practitioner and the cath lab up and running?
I know we just had the grand opening for the completely renovated cath lab, right? Oh, we had an internal. I'm sorry. We got marketing over here explaining to me. We did an internal open house for the cath lab, right? How about that? But it is functionally complete. Okay. And we do have a provider that's joining us January. He is in state, so we don't have to go through the process of getting him licensed in Tennessee and so forth. So we do have a provider under with letter of intent and a contract in place. So he'll be joining us in January, and we do expect that will pick up really quickly, Mr. Esquivel.
Okay, thank you. And so you addressed some of the discrepancies on the expenses, so I appreciate that information about the Cerner implementation and the increased contract costs. But could you describe another sort of year-to-date, fiscal year-to-date discrepancy on the expenses is the salaries between about 15.6 million and around 17 million. What it is that's causing the deviation from the expected salary expense? A
good chunk of it is we're employing physicians that used to be provided under the PSA agreement. I mean, when there is no oncologist, or when they can't cover OB 24/7, or when they quit covering the ER for psychiatry, the hospital has to backfill those, and we end up employing those providers and their NPs and so forth. So unfortunately, now eventually we'll start to generate revenues from those providers, and so my revenue should float as well. Previously, Meharry would have billed for those provider services, but I don't think Meharry was making money on that trade, so that's probably why they let those services sort of lapse, and then we had to backfill. So I'm not saying that's exclusively it, but every physician that you bring in is hundreds of thousands of dollars, and in some specialties it's $500,000. So we do take those on, and that does hit our salary line. That drives a big chunk of this.
And was that, since that, having just recently joined the board and not been part of the previous, most recent budget process, was that an unanticipated expense?
We have to put the budget, literally we'll be putting the budget together in December to present to this board before we go to Metro in late February or early March. And there are just, we don't get notice of they're not going to renew someone's contract over at the college or so forth. And we even lose our own recruited physicians sometimes. We've lost a couple of our own physicians recently to FEMLA and so forth, and we hope to get them back. But, we're a small medical staff, in terms of employed medical staff. And then the PSA, as Meharry has either stepped out of some of those services, we really don't have a choice about having a pathologist or a radiologist here to cover the hospital. The obstetric program, Meharry used to cover 24/7, 365. They just don't have enough bodies to do it currently. They've been honest with us. We had to employ an obstetrician for the first time, 3 midwives, I believe, and all of that's a $500,000 investment annually. Now, eventually we'll get revenues from those as well, but we have to still fill those services because we're 24/7. And I'm just a finance guy. I promise you, these are much more complex. I just see the downside of them.
Yeah, I guess it seems like one recurring theme is providers that we're having to employ that we previously did not. And I understand once we employ them, we have the benefit of getting the revenue for the billings.
Yep.
But I guess as a finance guy, what's the projection of when we employ them, there'd be a lag, but once the billing comes in, do we anticipate that we will offset the cost of the contracts with the revenue from the billing? Or
I think it varies by specialty. With obstetrics, it's probably not a great bet that you're going to cover it, but you have to have the service 24/7. With interventional cardiology, I would expect we'll produce enough revenue from that individual between his billings and the technical side, that it will cover its rear end. It just varies by service. Primary care, our Metro Center clinic, we took them over in February. They were not budgeted. We took them over in February. Their expenses are about $100,000 a month. Their revenue collections are $105,000 a month. So they're covering theirs. But that's unusual in primary care, I'll just say, in most hospitals. So we've got one very high-performing clinic there at Metro Center. They do a good job, and they cause me no problems because they're paying their way every day. We just need to make sure that we get more of their referrals and make our specialists as attractive to them as they have been in their previous referral processes. So.
Great, thank you. There's a line for capital contribution. The net income or the net deficit is offset year to date by a $2 million capital contribution. Can you explain what that is?
That is when we draw money from Metro for capital, because when I purchase it, it just has to go somewhere. So it typically goes into expense. And then when we get reimbursed, if we have to send it to Metro after we purchase or pay for it, Metro does reimburse us dollars that are eligible, and that tells you that there's been about $2 million that came back from Metro to reimburse us for capital costs.
Okay.
Okay.
Just two more questions.
That's okay.
One is, would it be possible to get a more specific breakdown of the expense line item for other, because it's one of the larger budget items, and it doesn't give us much visibility into what other is. So if it'd be possible between now and the next board meeting to get the line item report, that would be helpful, because it's another one that year to date is among those that is not meeting budget. And then my last question is a very big picture question, which is just looking at the trend for the first quarter of our fiscal year. We are, so the capital contribution I understand now, but so that makes sense. The change in fund balance is a deficit of about $2.5 million. What can we expect over the remaining quarters as to what that number is going to do? Should we anticipate that it's going to add to the deficit? Do we think we're going to make that up? Like what is going to happen in terms of the discrepancy in the revenues versus expenses over the next quarter or two?
Yeah, I would say in a quarter, it'll get a little better. I would expect by the end of the year, it will get significantly better. We're not going to lose $2.5 million every quarter.
Well, I think that's all right. You're right.
I just say that. I mean,
exactly,
there are investments. You know, we're early in the game at the Bordeaux Clinic and the urgent care and that diagnostic center. They're $100,000 a month expense plus rent, and they're producing very little because they just really opened. So we've got investments that are being made. I think they're good bets for the hospital going forward. I would look at the admissions versus last year. And last year we grew about 12% on admissions. This year we're about 7% on admissions. Our clinic volumes are up about 30%. And I know that's all looking forward, but I think it's moving in the right direction. But I'm just like you. I don't like, we had really great, right before you got here, David, we had some really good end of the year reports for the FISC 24, and we started off a little bit of a ditch in the first quarter of 25.
I was like when things improve. So this is fantastic sort of expectation setting. Yeah. And in true lawyer fashion, I do have one more question. That you talked about the admissions. So what I noticed from the statistics is that a lot of the admissions data exceeds what our projections were, except for the observation days. Yeah. Average daily census, the average length of stay are significantly lower. So just, again, in very general terms, what is the effect on budget among these various categories? I mean, how important are their observation days from a budgetary perspective as opposed to inpatient and the other categories?
Yeah, and I don't want to bore. I know we've got doctors in this room that know this that we play, but the challenge, what we like is to conclude on patients within 24 hours of their being admitted to a bed. But until there's a definitive order and they meet all the clinical criteria, they have to stay in that observation status. So our job as a hospital is to get those through as quickly as possible. A year ago, the average observation stay was almost 2 days. This year, it's 1 day. So we're concluding on those patients, either they're getting admitted with a proper order and with all the criteria, or they're being discharged timely. And that's what you want to have happen. You don't want patients that don't need to be in the hospital. And the only impact it has is that an observation patient, even though they're on the floor, that's outpatient revenue. And so I know it's all very complex. It seems like if you're not in this business, but I want my observation length of stay to be short, and I want my length of stay for patients in the house to be short. I don't want it to be too short because I don't want them to come back with the same issue, right? Because that's a readmission that doesn't sit well with quality. But we do want them to move as rapidly as we can. And our utilization management team, and Dr. Blackledge, I'm sorry she's not here to hear it, but they're doing a really good job of taking care of patients as timely as we can. So they do mess with my numbers because I'm using years of history when I estimate how long they're going to be here. But we're out-kicking the coverage right now. But it does have its impacts on gross revenue, not net.
Bruce, it might be helpful what you shared in the Finance Committee meeting and just describing what that lag time looks like for these newer facilities as it relates to licensing from the state and then getting kind of like approved.
I know that Dr. Blackledge does it so much more eloquently.
I think it will help in that lag time and understanding how this amount of money that we're seeing that we're kind of in the red won't follow us necessarily.
We were talking about the diagnostic center. We have a freestanding imaging center that opened at Bordeaux. And, you know, the challenge of that is you have to meet all the state and federal licensure requirements before you can open. And you can't get a contract with any payer or Medicare or Medicaid until you're open and you have the license from the state. So you've got all your people there in that 60 days before you can even technically be approved to open, but you don't have any payer contracts, and those take 60 days. So we've got 5 or 6 people, a lot of expensive equipment that we're paying a lease on for 120 days before we're going to get the first dollar probably from that. And those are big expenses. But I'm going to tell you, that's an investment that we made in that community. That imaging center is going to be, I think it'll be a year and 18 months before it really starts kicking in. But I think with a little marketing and its physical location, surface parking, I think it's going to be very attractive, and I think it will make money for the hospital, and it will also attract new patients to the hospital once they get their studies done. So that's the goal.
Great, thank you. I appreciate that very much, and especially the education about the observation day. So now I know how to read that as good news when it is that when the observation days are low. Thank you.
Just to tag on to that, in thinking about your budget, you know, your program, the FAST ED program, I would suspect that would really be something that would attract people. And so I guess that's a marketing thing too, but clearly that would be a source of revenue that should really bring in some.
And we didn't know about it when we did the budget, of course. I mean, it was something that I think it went up in April. And so it is. And I think what we lost after COVID, our ambulance drops and our high acuity visits they're not that different. What we've lost is our low acuity visits. And people were willing to go somewhere across town and wait. You don't have to wait when you come here. Our door to bed is 3 or 4 minutes. So you're seen within 3 to 4 minutes of when you present into the waiting space. It's not even a waiting space now, it's a family lounge because they take you straight back.
Well, I do see that as certainly a real advantage to capitalize on. And then also looking at who is the patient, let's just say maternal child health or whatever. Who is that patient that delivers here or comes here? And how do we get more people to come to do that? I mean, I know that there are personalities, I'm just going to call it, that you go to a certain place if you want to have a healthy baby, you go to a certain place if you have any high risk. But how do we capture the needs and how are we going after it in order to build up the revenue? At least some thought. You probably can't answer it today.
Yeah, I'm probably not the right person to answer that.
Right
Dr. Webb might
take
a shot
to
at
think
it.
about.
Let me respond to that, if you want a response. Did you want to respond?
Oh, absolutely. That would be
Okay.
great.
Well,
Yeah.
the way you do that is you expand the capacity of your providers. You bring on more physicians. We are in the process of recruiting additional physicians. And so those patients don't just show up and have a baby. There's a 9-month, well, you know that. So they do that with their providers. And then when the delivery occurs, if they've got a population of patients, then you start to expect a stream. But you also have those emergencies who will come in, and then you have those doctors on call. So right now we're building up. We recently took over that program, so we're building up the capacity in our providers.
Oh, well, that's very helpful in terms of thinking about, again, going back to your personnel issues that were clearly stated in the J code to think about. So I see all of that is tied in. So yeah, that's wonderful. So I'm just thinking about how do you visualize and also put that into motion in order to provide the needs of the community. And all of this works together. Just so thank you. Yeah, and I had 3 children, so.
All right. Any other questions?
All right, thank you, Bruce. With that, we will entertain a motion to adopt the finance report.
So moved.
Second.
It's been moved and properly second. Are you ready for the question? All in favor, vote by the sign of aye. All
Thank you.
opposed? Ayes have it. Thank you. All right, I think we've come down to our CEO report.
Let me first call on Ms. Kathy Poole to give a quick update on some announcements.
Good evening, everyone. And I can touch on what you were just asking really quickly. So as part of our marketing, we have put personas together for different types of consumers. So whether it's a Metro employee, because we know that that's kind of low-hanging fruit with the Metro Healthcare Incentive Program. Actually, we now refer to it as the Nashville Healthcare Incentive Program because it includes Metro employees, NES employees, and now state employees. And then, you know, who else are stakeholders in the community? Obviously, politicians, obviously, you know, who our partners are in the community, other providers. So making sure that those primary care providers know that we now have OBGYNs and midwives. And midwives is huge right now. You know, we actually had the market on midwives back in the 70s and 80s and early 90s. Unfortunately, when we relocated, we gave up the midwives and went completely with OBGYNs. And we hadn't really been in that space for a couple of years, so it was exciting when Bruce was saying that our deliveries have been up over budget, because 15 years ago, we were doing close to 100 births a month. And right now, we've been down to about 30. So it's great to see that service line come back to Nashville General.
Well, it certainly adds to the generational history
Yes.
of Nashville. And I can say that personally with several generations, even in my family. And then the physicians that have come through this place, you know, the Dr. Treherne and, you know, Dr. Foster. You know, so,
There's a
you
lot
know,
of rich
there's a lot of
history
history. So
between-
this is exciting.
Right.
And so I'm glad that's why I kind of asked, do we have a target and a vision? Because that gives you framework
Yes.
to what you need to do.
Definitely. So just a couple of things I wanted to make some announcements about. Miss Veronica Elders was named CNO to Know by Becker's Healthcare Magazine early last month. Nashville General was actually named one of the best hospitals for Black America 2025. That list came out. Nashville Healthcare Pharmacy has officially opened at our Metro Center location. News Channel 5 had a story this morning with the manager out there, Jeff Hardwick. And they were, yes, they had some great press recently. And for anyone who listens to 92Q, Kenny Smooth, Dr. Crayon, one of our family medicine providers at that Metro Center location, was on there yesterday morning speaking about diabetes as part of Diabetes Month. So we also have Dr. Webb, congratulations to him. He was named Citizen of the Year by the Gamma Phi chapter of Omega Phi Psi this last Saturday at their Harvest Ball. So congratulations to Dr. Webb and the recognition he received. And just making sure all of you are following us on social media. We had those QR codes out. We had everything out there from the STEM Goes Red event that was hosted by Meharry. We had great participation by our providers, the NGH Foundation Pet Therapy. We got little dogs that ran around that looked like leopards. It was amazing. Took 6 hours to paint a dog. Not sure how the dog managed that, but just little things that are going on at General as part of the community. We had a Veterans Day breakfast, our Daisy winner, and then also I want to give a shout out to my team if they would stand up. It is National Healthcare Strategy and Marketing Week. And then we'll be sending you emails. We'll have 2 events the month of December, an employee celebration and our Secret Santa event, which is absolutely wonderful. We've been doing it for about 10 years now, and we hope you will be able to come to those 2 events. Dr. Webb, thank you.
Thank you, Ms. Poole. And while we're in a celebratory mood, I want to also announce that we have received the Leapfrog safety grade results, and we have an A. There's your A. And that is the highest you can score. It is it reflects the dedication to patient safety, reducing medical errors, infections, and preventable injuries. This is a national level acknowledgement, NGA's efforts and high standards in healthcare quality. We are one of 3 hospitals in the area out of 17 that received an A. So and that obviously requires a lot of work on behalf of our clinical staff, and so kudos to all of those that participate on a day-to-day basis to achieve that quality score. I want to also point out that we have had the board support our initiatives over the past year, like the cath lab updates, which, by the way, that is a state-of-the-art lab. We celebrated the open house. It is operational, and we will be doing cases there shortly. Also, the expansion into Bordeaux, as well as Metro Center, and we appreciate the board's support on supporting us in those areas. And as we are able to engage in those type activities, we can add to our bottom line, grow our fiscal sustainability. Now, the one thing that we spent a lot of time talking about today is that lag time. And I like to reference it as, it's not like a donut shop. You don't put the donuts on the shelf and, I mean, you sell them and you immediately get the cash for it. In this case, you put the donuts on the shelf, someone buys them, and then you wait 6 months. So it's a little bit of a lag there, but we will be seeing the fruits of that labor here shortly. I also want to thank the team for the great work that they did on the Joint Commission survey. Kudos to all of you and the accolades that we did receive from the Joint Commission team. I want to thank our chairman for coming to the leadership session. That was they were very impressed by that and his knowledge of what's going on in the hospital, particularly around recognizing the need for a new facility and those aspects. I also want to thank Mr. Lesser, who has taken me up on my invite to the board members for one-on-one meetings. He's had several, we've had several, and he is, in the last meeting, he asked that question, what keeps you up at night? So I appreciate that, and you know, not a lot of things do that. One area that I would like to encourage the board to to work with us a little more on is the Metro incentive program. I think that's a tremendous opportunity for us to help to also grow revenues for the hospital. And whenever we grow revenues, that helps to offset our need for any subsidy or dependence on that, even though the subsidy is basically associated with the indigent care coverage. And it's a little bit concerning when you hear that you get this large subsidy. Well, the subsidy is really associated with what we submit in that line item that says this is the projected cost for the indigent. And as I stated at the last meeting, in keeping with the charter of the city, which states that it would cover that cost. That's basically what that is referring to. Lastly, just want to acknowledge the Nashville General Hospital Wellness Champion for 2024. And I'm proud to announce that we had 64 employees across 27 departments. That shows a 20% increase in participation over the last year in the wellness program, with a total of 426 pounds lost. So I'm just going to run through the winners were the second year in a row laboratory with most participants of 9. The third runner-up in the actual competition was Gladys Assar. Second runner-up was Whitney Jackson. First runner-up is Crystal Benz. And 2024 Wellness Champion is Wendy Colgan. Is Wendy here? Okay. Okay, so that's the end of my report. Thank you all. Happy to answer any questions that you might have.
Dr. Webb, specifically, how can we help with the Metro incentive plan?
Well, I think it's a little bit more engaging than what we could really resolve here. We know that our customers still receive a bill, and we've been trying to work on an opportunity to have that change so that it's not misleading, because for copay and deductibles, they shouldn't be receiving a bill. Even though they don't have to pay it, they still receive it. So it's not built into the system such that the system does not push a bill out to them. So, you know, it's all a part of the mechanisms of how the process is structured that tends to deter people from actually taking advantage of something that could really be helpful to them. And the cost to the city is much less as well, because our services here are not going to be at the level of the cost of other hospitals in the city. So it's a two-way benefit. Actually, a three-way.
But it's one thing that you asked for the board's help on. What specific things can we do?
Yeah, I would like to deal with that offline, if you would, because it gets a little more engaged than what more so than what we can cover here at the board meeting. So we will follow up with you and give you some more insight into how we can utilize your help. Thank you.
Thank you, Dr. Webb, for your report. I don't have a report other than just to suggest that maybe we reconvene in January and not try to push the December meeting. I understand that the hospital staff will be implementing CERNA during that time, and so I want to give them an opportunity to be fully engaged. And then I think it's important for you all to be with your families during that time. But we've lifted the threshold for contracts, which was one of the reasons why we would sometimes have to come and rush back to do these meetings. Last year specifically, we had to come back and do it. But with the new policy and the threshold, I think we'll be okay. So we'll set the meeting for January. With that being said, pursuant to TCA 68-11-238, the board may enter into a closed session to discuss marketing strategy sessions and plans, and we have that on our agenda. Of course, no other business may be discussed during the closed session. No voting on business or a deliberation towards a decision will take place in this closed session. It will require a motion that's properly second, and we will need a roll call vote to go into this session. I would also like to note that after this closed session, there's no more business that we will conduct when we come back in session. We will only come together to adjourn. And so therefore the live streaming will end after our roll call vote, because we will not be conducting any other business once we come back. So at this time, I would like for us to go into strategy session, but we will need a roll call vote for that to take place.
I move that we enter into strategy and marketing session.
All in favor, vote by sign. No, roll call vote, sorry.
Esquivel?
Aye.
Hudson? Yes. I mean, yes. Yes. Thank you. Lesser? Yes. Martin? Yes. Miller? Yes. Nettles? Yes. Stevenson?
Yes.
We have a quorum.
We are adjourned into strategy session.
This has been a service of the Metro Nashville Network. If you would like to see this presentation again, or for more information on this and other programs, visit nashville.gov.